You already know loop diuretics, you know thiazides, you know potassium-sparing agents, but there is one subclass of diuretics that does something the others cannot. They block a hormone receptor, and in doing so, they protect the heart, the kidneys, and save lives. Today, on RxRasha Pharma Basics, we are talking about Mineralocorticoid Receptor Antagonists, MRAs, Spironolactone, Eplerenone, and Finerenone. Let us start with the mechanism. Aldosterone is a hormone produced by the adrenal glands. Its job is to tell the kidneys to retain sodium and water and to excrete potassium. When aldosterone is overactive, it causes fluid retention, hypertension, and critically, it drives fibrosis and inflammation in the heart and kidneys. MRAs block the mineralocorticoid receptor, the same receptor aldosterone binds to. Block the receptor, block the damage. First, spironolactone. This is the original MRA. It has been around since the 1960s. It blocks aldosterone but also binds to androgen and progesterone receptors. That is why it causes gynecomastia and breast tenderness in men and menstrual irregularities in women. Despite that, it remains a powerful drug. It is used in heart failure with reduced ejection fraction, resistant hypertension, primary hyperaldosteronism, and liver cirrhosis with ascites. The RALES trial showed it reduced mortality by 30% in severe heart failure patients, a landmark result. Second, Eplerenone. This is the selective MRA. It was designed to fix spironolactone's hormonal side effects. Eplerenone binds only to the mineralocorticoid receptor, no androgen or progesterone binding, so no gynecomastia. It is used in heart failure post-myocardial infarction and in hypertension. The EPHESUS trial showed it significantly reduced cardiovascular mortality in patients with heart failure following a heart attack. The trade-off? It is weaker than spironolactone and more expensive. Now, Finerenone. This is the new generation MRA, and it is different in an important way. Finerenone is a non-steroidal MRA, meaning it has a completely different chemical structure from spironolactone and eplerenone. This gives it more selective and balanced tissue distribution, a stronger activity in the heart and kidneys with less effect on the kidneys collecting ducts. That means less hyperkalemia risk compared to the older agents. Finerenone is approved specifically for chronic kidney disease associated with type 2 diabetes. The FIDELIO-DKD trial showed it significantly reduced the risk of kidney failure and cardiovascular events. The FIGARO-DKD trial confirmed cardiovascular benefits. Together, these trials establish Finerenone as a cornerstone of cardiorenal protection in diabetic kidney disease. Now let us talk about the side effect all three share, hyperkalemia. Because MRAs block aldosterone, potassium is retained. This is the most important monitoring parameter. Always check potassium before starting and monitor regularly, especially in patients with CKD or on ACE inhibitors or ARBs. Contraindicated if potassium is above 5 milliequivalents per liter or if eGFR is severely reduced. Quick comparison. Spironolactone, non-selective, cheapest, most hormonal side effects. Eplerenone, selective, fewer side effects, moderate cost. Finerenone, non-steroidal, most selective, best cardiorenal profile, approved for diabetic CKD. This is Rasha with RxRasha Pharma Basics. MRAs are not just diuretics, they are cardioprotective, renoprotective, and in the right patient, life-saving. If this helped you, share it with a colleague.